Welcome to our panel session on current trends and shift in employee health and protection benefits. I can see a few people still coming in. If you're wise, you'll probably try and sit here in the centre, and you'll be able to see the panel quite well and ask questions, and there are plenty of seats, so I recommend coming across on this side of the room. While we are all settling in, could I ask that you have your phones ready, logged onto the Wi-Fi, and ideally also logged into Slido using the QR code that you can see on the screen, because I'm going to be kicking off the session with a couple of polling questions just to set the scene for our discussion. And while you are doing that, I think it's probably a very good opportunity for me to introduce my fabulous panellists. And in fact, it's a bit of a reunion tour for some of the panellists. We've done this before, and it's gone so well that we thought we'd bring them to an even bigger audience. So think of this as the O2. So I'd like to start introducing, starting on your extreme right, my extreme left. Never a good way of doing it for somebody who's got no idea about direction. We have Jake Saunders, who's Global Wellbeing Lead at Diageo. Then sitting next to him is Danny Masters, who's Director Global Health and Wellness at Generali Employee Benefits. And I'd like to pause at this particular moment to say a very special thank you to Generali Employee Benefits for supporting this particular panel session today on this very important topic. And then next to me, we've got Dana Citron, who's Director Global Health and Wellbeing at DHL Group. All hugely experienced, all coming from slightly different backgrounds, although we did discover a couple of synergies on Monday with two of the team having sports science backgrounds and know a lot about data and things like that. Right, hopefully, I think we've got most people in the room now. I think we've hopefully got most of you logged into Slido. And have you managed to find that we're in partnership room? I forgot to tell you that little important key nugget of information on Slido so that the correct polls come up. So yes, if we can have the first poll, I see has already come up. So what I want to find out is, this is your employer-funded medical benefits. So this is, I'm talking here specifically the PMI health insurance. I'm not talking protection benefits, I'm not talking risk, I'm not talking income protection. So specifically the health medical benefits that you fund in whatever funding mechanism you use. What has happened to your costs over roughly the last 12 months? I just want to get a bit of a feel for what's been happening in the room. So looking at this data that's already coming in, over half, between 20 and 50%. I'm looking across at the panel. Does that look about what you're seeing across the market? So that's a massive increase. I mean, way above inflation. Just over a quarter of you saying less than 20%. I realised last night I probably should have split that answer down into a bit more detail. Apologies there, because I don't know whether that's 2% or whether that's 19%. But it gives a bit of a flavour. And then we've even got 12% of you with over 50% increases. And I think that's, in a way, I wanted to flag that up. There's almost nobody saying it's reduced or stayed roughly the same. So a big issue around those medical benefits and the costs that are impacting you as employers. If we can go across onto the second polling question now and bring that up, please, at the back of the room. Thank you. So now I want to find out, when it comes to your risk and protection benefits, income protection, death in service, critical illness, or whatever it is called in different countries around the world. I think you know roughly what I mean by those, because this should come up with a slightly different pattern. So there you suddenly see it's roughly stayed the same, quite a big group. And I think that's from all the calls I've done with insurers recently. It's a different dynamic happening in that particular market, and we may touch on that in the panel as well. So very different shape when we talk about employer-funded health and protection, how it's playing out, and just diving in a little bit deeper. Thank you for both those polls. I think the session today, I want to dive straight into questions with the panel. So what I'm going to do is probably the first 20 minutes or so, we've got some pre-prepared questions that we're going to talk about among the panel. And then once we've done that, I will then open questions to the floor. So I won't bring up any Slido questions just yet, but no, if you have any that tucked away that you want to ask, you can pop them into your phones now, and they'll be ready waiting for us when we open to questions. I think the most important thing to do to start the session is, I want to come to you, Dana, because we were talking about this understanding. Everybody goes medical inflation, insurance inflation. The term we're going to be using is medical trend, which is a bit of a broader term. So when you talk about medical trend, Dana, what are we talking about?
Yeah, I think it's important to understand that medical trend and medical insurance in general is one of the few benefits that's not linked to your salary. So medical trend plays a big role. It's usually looked at as the unit cost, so the amount that you're using the amount the service costs, and the utilization, so the amount of times you're using the service. With healthcare, what's different is that you have two different demanders coming in. So you have us as consumers, plus you have the healthcare market. So those are the things that you have to think about when you're thinking about the medical trend. And it's usually on average about 3 times general inflation in a country. And to put that into perspective, the best way to try to explain it is that if you take a country where the medical trend is about 12 to 15%, your costs are going to double in about 5 to 7 years. And during that same time period, the actual cost of a good or a gallon of milk only goes up about 18%. So it's something that we really need to focus on, understanding what creates the medical trend, what's driving it, because the costs continue to grow exponentially year over year.
So picking up on exactly that, what is driving it, I want to come across to you, Danny, and what are the shifting trends and the inflationary pressures that are making the price go up and causing employers to rethink what they're offering?
Yeah, so as Dana said, medical trend is made up of a lot of different things, and one of the things that is influencing medical trend is general inflation. We all know that general inflation has been a huge topic over the last few years, hyperinflation in many markets. You've seen the news yesterday, general inflation in the UK has just dropped to the 2%, so yay. Right, but everywhere around the world, we've seen those trends of hyperinflation, and they will impact healthcare costs as well. So that's definitely one big point. But we also had some socio-economic circumstances in general that were impacting healthcare costs. So that will be reflected in the trends as well. Now, specifically to the UK and some other countries with a very comprehensive national healthcare system, we have actually seen that those healthcare systems have been overwhelmed after the pandemic. Nobody wants to talk about the pandemic anymore, but there is still the aftermath that we're dealing with. So there has been a shift to the private sector that we've been seeing. So the utilization of private healthcare has gone up quite significantly because of the pressures on the national healthcare systems. So I think that's a really important one to look at, especially here in the UK as well. And from a global employee benefits provider perspective, where I sit, I can say that, you've been all saying, well, your costs have gone up for medical insurance by 20 to 50%. That's a huge increase. Globally speaking, our portfolio tells us that claims have gone up by about 20% as well, while the exposure hasn't changed that much. And what I mean by exposure is how many people have access to using a benefit. Because it's one thing that you're saying, claims are up and premium is up, but you always have to put that into perspective of how many people have actually access to the benefit that you're utilizing. So there is a misalignment at the moment in terms of how many people can access the service and how have the costs gone up, whether for premium or how much we're paying in claims.
Interesting. So coming to you, Jake, so as a Wellbeing leader, how can people responsible for well-being and purchasing these benefits work both with your reward and benefits teams and with insurers to maximize spend for benefit at a time when we have this out of kilter medical trend?
I think we've seen over the last, especially going back to the pandemic, a trend of roles like mine with well-being in the title and Dana like yours, where probably where it sits in an organization, company to company, I'm sure people in the room have this experience where it can sit in a variety of different areas and different controls and different structures. I think the important thing, and we've seen this since I've joined Diageo, is that there is a commitment, and has been a commitment, that we need to have cross-functional working and that actually be formalized in advisory groups within the organization. I think it's really keen, and something that has been in the first 6 months of my role is working very closely with our global reward team, working with our HR, COE for inclusion, diversity, learning, and well-being. And for me, I sit within occupational health, so it's a slightly different angle of approach. So we get to see and start to bringing those people around the table. And while it's not a perfect system, and while it's not an absolute system, I think it's important that we think about getting a variety of people around the table and thinking about how can we design with well-being in mind to start to approach the problem where you can go, because some of it is structural, some of it is behavioural. And I think, Danny, as what you were saying there, in terms of we can see that in some countries, it's actually how, and we can see it in the NHS here in the UK, how people approach healthcare and when you use it. Is it you can go down to the shop, buy some ibuprofen or paracetamol and sit at home with a headache, or do you go to a medical centre? Both of those things end up in the same outcome, but have vastly different costs. So I think there's a behavioural element as well.
So coming back to Danny, I think there's a role, we were talking about this the other day, the role that the insurers themselves, or those overseeing captives themselves, can play as well, bringing down costs. Can you share some of the things that your side of the fence could be doing or are doing?
Well, I think it all comes down to really using the available data that is there. And I think what Jake is saying here is a very important piece. I think insurer and employee benefit networks can actually be a part of bringing the right people together. And I can tell you that this is a great example, prime example of how it should be done. I know that Dana is working with the teams and the entities locally as well, very closely to kind of bring the right people together, but it's not happening everywhere. The clients that I work with often are very disconnected. And the reason they're disconnected is because the captive or the pool manager or the EB manager have different goals than the CFO, and different goals to the EB managers and the health and well-being people. So I think the role that the networks and the insurer can have in this scenario is to really try and bring everything together and work with everyone to understand goals and what is, what can be done on all levels to change something. And the basis for that is the data that we get. And the data can either be your medical claims data. You should all have access to a wealth of information of why people are claiming on your medical benefit, how they are claiming, the behaviors, what medical providers they are using, and then use your insurer's knowledge to kind of start think about how can we maybe manage costs? Like, we do have to manage costs. If they're, like Dana said, doubling every 7 years, we have to do something about it. We want to, of course, provide access to care. That's very important to all of us, that our employees have access to care. But at the same time, we have to, make decisions about how can we control costs. So that's network provider management. Do they have to go to the most expensive hospital or provider? Or can we bring them to cost-effective care that, it brings the same quality? Is it maybe about health and well-being programs that are integrated into your work health and safety strategy? So, and then culture, like Jake says, makes a huge difference how you approach health and well-being in India compared to how you approach health and well-being in the UK or Spain. And the insurer can help with that, with the local knowledge and the data that they provide.
Very helpful. Now I want to hear from the two employers about some of the solutions, the tactics that you're using to help manage and mitigate those future cost increases. If I can start with you, Dana, and then Jake, and then I can see a few questions have come through on that, so I'll jump to those in a moment.
Yeah, I think for us, and I've spoken about this before, at DHL, I'm a part of the insurance captive, so sit in a very different area than Jake and probably a lot of other health and well-being leads. But we utilize that, and I think that it's helped us build from the ground up, but I wouldn't say that it needs to be the driver, because we are setting the pricing for the medical insurance, and we knew that if we did nothing, that costs would continue to go up. So we actually started betting on our business units and put in a program where, by focusing on impactful health and well-being programs and looking at your data and using health to manage costs, that we would give a discount on the medical insurance up front. And then in order to get that discount the next year, they report the initiatives within our framework, and then they get a gold, silver, or bronze. So we use that as a carrot back in 2015. I think now it's gone to a different level in terms of we are now working across one whole division, whether they're with our captive or not, and it's a part of the goals of the HR it started with. So HR, health and safety have been a big part of how we have built this. So what we really talk about is, again, what Danny had said, going back to using the data, because you need to understand why your costs are there. If you're looking at using your medical insurance as an absence management tool, it's a very expensive absence management tool. If you think about how much, as soon as you go into your doctor and you need a sick note that first day and they walk out with 10 different prescriptions. So it's really looking at what is driving that, what can you do with your plan design, what can you do with the actual facility, what you can do with your health and well-being programs, and focusing on those rather than focusing on just the trendy things that are out there that we just want to give everyone everything. It's about the value and the health impact.
Which probably picks up quite nicely for you, Jake. What are you doing at Diageo to manage these?
The value and health impact is the key part, and that's part of my role, is to review how do we approach well-being, how do we approach measuring well-being. Being the primary goal for me over the next 18 months is actually how do we measure impact and how do we look at that, and the sources of data being important for that, and actually being able to track and look at if people have, and building a wellbeing index into our engagement survey, and then looking at that data in correlation with what are our claims data, what's our attrition, what's our sickness absence rates, so that rather than estimating cost, we can start to say this is the actual cost of declining wellbeing across the organization, and then compare that to what is considered best practice for approaching wellbeing within localities, and it not being a global, like you must do this, but it's around how we can actually coach and get out the way of local countries doing what works best for them with the guideline of us globally. I think tied to that as well, and pick up a little bit what you said, Danny, I think that there's an importance, and to give context, I've sat on both the insurer side, the provider side, and now internal, so I've had kind of over the last 8 years, I've sat with a variety of hats. And my experience internally is that people aren't necessarily good buyers, where they don't share with their providers, even people they're already paying, they don't share with them the problems they're trying to solve accurately. And I think there's a challenge that if you go to your provider, and I remember from being a provider that if certain clients had just told me what they were actually trying to solve, we could have done a lot more work and it wouldn't have cost any more. So I think there's a challenge to people is be a better buyer and tell people the problem you're actually trying to solve. And put that challenge to your providers, because I think you'd find that you'll get a lot more out of that relationship.
Well, that's a big challenge, because it needs the companies to actually have a very honest look at their own kind of culture and how they're doing things. I want to add one thing which I find very fascinating listening to both of them, and I have sat on the client side myself before. They're both speaking about a very altruistic approach to their strategy, right? Because what I often see happening is that there's a major focus only on the main trends and cost drivers that we see in the medical data. But instead of thinking about the bigger picture of long-term prevention and how this can, if you have a turnover of every 3 years and you say, well, I'm not going to focus on diabetes prevention because the person will have left before my prevention program has anything, has done anything, then you're kind of missing the point that this is maybe a problem of public health rather than just the insurance benefit that we're looking at.
Thank you. I want to bring up the polling questions Sorry, not the polling question, the Q&A now up onto Sally, because there's one that's come up which I think is going to be an interesting one that I'm hoping, I'll certainly come to you, Jake, but others may want to comment, and that's that top one we can see at the moment. And GC providers possibly introducing a wider range, I'm going to say insurance plans, let's keep it open there. Oh, it's shifted there. To help employers manage costs like dental plans. Now, Jake, you and I were talking about this on whatever day we did the briefing call, Tuesday, about people rolling up everything into insurance and managing costs and things.
Yeah.
I'm going to start with you and then come across to you, Dana.
Yes, what we're talking about, I think it's really interesting that there's definitely been a trend since COVID of everything being rolled into your private medical and everything being an insured benefit. And I find this really interesting because naturally an insurance product is there for the worst case scenario. And maybe it was a reaction because in 2020 claims dropped through the floor because there were public healthcare systems being backed up by private healthcare systems, and therefore insurers had to provide more value for the cost. I certainly was working for an insurer at the time, and certainly my job role changed. But I think that as a consequence of that, that's also going to add to the inflationary pressure. So if we try and roll everything into a singular insurance product or insurance products, it's going to have an inflationary pressure. Whereas if we can start to pull some things out of private medical, or pull things out and have a variety of options that maybe aren't necessarily insured for those that, and for those that don't have captives, it's not within that space. But it's actually point solutions which are available only for those that actually really need it. And then you can be super targeted with initiatives.
And a prime example that we spoke about was, for example, the health checks, like the routine physicals or annual health checks that you might be offering, or the cancer screening, the preventative cancer screening. Should that be an insurable benefit? Because as you say, it's for the unpredicted circumstances that you have insurance for, not for the planned costs that would come on a regular basis.
So I come to you, Dana. I know you've got a captive, I'm sure you've got views.
We always look at a captive as self-insurance, but when you're talking about, the unexpected versus expected, and when you're talking about dental for the preventive aspects, you can cost that out. You have X amount of employees, so it's something that you have control over. So does it need to be insured? Not really. It can be more of, we still take it within the captive, but it's a planned cost. Whereas insurance, as Jake said, is meant for the unexpected. And so having that be a part of your insurance, again, it's driving up costs sort of where you don't need to be, because you can plan that in your budget. You can plan those screenings in your budget based off of how many, your population, the age. So it's a more planned cost. So we actually still take it, but it is sort of that administering the service rather than the insurance aspect of it.
Fantastic. I'm going to get on to a question about data shortly, but there's one that's just popped up on screen that I think I'd like to ask, and that one is, as treatments get better and more expensive, we will see more high-value claims coming through. Is there anything we can do to mitigate these costs? Because we see medical advances, we can solve more and more, but it costs more and more. How do employers manage, and I'm looking at you in the first instance, Danny, but I can feel Dana desperate to answer it as well. So answer from you and then across to Dana.
So there's two aspects to this that we kind of want to think about, because as treatment is advancing, yes, it becomes more expensive, but it might also become more effective. So it's not necessarily that a higher treatment cost results also in higher overall cost for the claim. It could, but it doesn't necessarily is an equal kind of thing. Sometimes you get out of hospital quicker. Like, I'm just thinking about my father. I remember like 20 years ago, my dad had a meniscus operation, and he had to stay in hospital for like 6 days. And then 5 years ago, he had a meniscus operation, and it was a day case. So what I mean by that is, as treatment is advancing, it might actually also become cheaper. So it's not always the same kind of equation that it becomes more expensive. But yes, certain medical treatments are more expensive, even if the outcome is positive. But what we can do as an insurer, and I'm just speaking as an insurance person here right now, is that we can, and I mentioned this earlier, really look at the providers that we're working with. Like, can you as an employer discuss with your insurer which providers your people are going to? Are they going to the 5-star one, or can they go to the 4-star one to get the same quality of care? Can you maybe increase member cost share components, a tiered network of medical providers? So if you want to go to the 5-star hospital, you can pay a little bit more out of pocket rather than with a 4-star hospital. So there is levers that you can take as an employer where you still allow the access to care, but you might have some cost reductions by implementing these kind of benefit and health plan management changes.
Thank you. Dana?
Yeah, and just picking up on that, it's also our definition of a 5-star hospital is about how nice it is. I think we need to shift that definition to how great the health outcomes are, because that's really what we should be defining care by. And I think that's a lot that we have to do with education in terms of speaking, the insurers can help with that and educating the clients, but also with educating the employees is that it's about the health outcome. It's not about having the nicest room, because that's not quality care. I think, for us, what we really, and the question sort of came up from the captive perspective about all the targeted genetic medications that are coming out, and how do we manage that with the risk, more so than actually the cost of it. But what we had started to talk about is the fact that it becomes under the same umbrella of if you have a high cost pregnancy issue. Doesn't happen that often, but it's something that you need to consider. As Danny said, in some cases, it is more cost effective. In other cases, it's also looking at and working with the health insurers to look at the newest isn't necessarily always the best. So are they looking at the data, looking at the pathways, how often are they reviewing them to make sure, because again, it's about having that health outcome, which then can help lower the cost, rather than, I know this is new, I want it. And that's one of the issues with medical trend, is that we as consumers are going in and demanding what we want, rather than listening and having those conversations and understanding what could be best for us.
So I think this was probably a good moment to start looking a bit more at data and so on. And I've just done that panel hosting blank thing about polling questions. I think I had a third polling question set up. Yes, I'm getting a thumbs up, and I can't remember what it was, so it could be as big a surprise to you as it is to me. Right, if you had to guess, how will use of AI change medical and risk-benefit costs? So I think we've kind of been given the answer already. So this is one I prepped a few days ago, you can tell, which is why I'd forgotten about it. Interesting. So there's actually a lot of positive view on that. So would you reduce costs or won't change costs? And a few people thinking it's going to increase costs. So I quite like that answer. And I think that's probably partly your answer influenced that. So I want to move across, if we can go back to the Slido questions. Thank you everybody for answering that. That's a very useful insight there, and go back to the Q&A. But while we're switching to talk about data there, I'd like to come to you, Jake, because you've done a lot looking at data and so on in your previous roles, and again where you are now. But what do you think the impact will be of AI, machine learning, and so on transforming access to health and well-being?
So I think there's a caution that we can have with AI, because AI is a very sweeping statement now. But if we talk about machine learning, which we've had in most well-being providers you go speak to have a machine learning model in some kind. And then we spoke on Tuesday about language models, things like ChatGPT, and what can be used with that. And I think that we have the ability as organizations to be cautious, because the medical tech space itself is actually, there is a bit more regulation there than what is delivered in hospitals and in healthcare systems than what's delivered in companies. So I think we can be cautious and allow the healthcare systems to test, to implement, to bring things through, to have things presented to us by insurers as options within our treatment, to not necessarily bring it into our own well-being strategies first and foremost. But there may be some value in things like the language models for things like signposting, for very surface level signposting to speed up and to support individuals. And I also think it comes into that conversation around who's responsible for well-being. I love talking about there's a dual accountability, there's a deal that we have, that my role as an individual when I turn up to work, I have to look after myself. That is entirely my responsibility and entirely within my control. That doesn't absolve my employer responsibility to make sure that there are the right tools, the time, the space to engage with those tools, but also to make sure the tools are actually fit for purpose. And I think that there is a dual accountability that if we start talking about that well, we'll start to build better trust. And then when you do things like bring AI tools in, it can probably be received by employees as a tool that's going to help them, as opposed to, oh, I'm just buying some AI to solve my problem.
So from an insurance point of view, how are you seeing things shift? How will the experience perhaps be different, or is it already changing anything from the claims process to admin to medical with this use of machine and AI? And what do you think you're going to see?
Well, I think there's a lot happening at the moment in this space, right? Especially when it comes to documents, reading documents, etc., how policy documents are read out and things like that. So there's a lot happening. But I want to pick up on the point, we're talking a lot about data, and I'm a health and well-being person. I have a background in sports science, but I can tell you that statistics and data were my weakest point, right? So I really had to learn data literacy. And I think this is really something where AI will hopefully help us in that space as well, because with, language models and stuff like that, we can suddenly ask questions for the machine to tell us what we need to know. And I'm being asked so much about data. Everybody wants more data, but then they don't know what to do with it. So I'm like, okay, so maybe that is the space where AI can really start helping us to pull out the key trends and cost drivers and the key pieces that we need to know about the amounts of data that we get, especially when it comes to the health and well-being space, and maybe even find certain correlations that aren't as obvious when you look at the whole data set in the beginning. I remember Dana and I had been working on a project last year where we tried to understand whether the initiatives that they do locally have any kind of impact on the claims experience, which was a great exercise to go through, but it was also a lot of work. So maybe AI can help with that in the future.
More work for you then.
So I want to just get some of the questions coming in. Absolutely great. And that top one, I think really there we talk a bit about telemedicine. So it's the online apps for whatever condition you've got. This one's focusing on mental health. And I'm just going to see if Dana might be able to pick this one up at all. So what tools do you use to help improve health, and have they worked? We've used mental health apps, for example, but engagement and ROI have been very challenging. So it's all very well talking about these things, but do they work, and how do you know what works well?
Yeah, I think it's really thinking about it. And so I'm a public health person by education, work in the corporate world because it's a great place to try and change behavior. But when we look at it, and when we're talking to our local business units about the programs that they're looking to do, I always say to start with, what's the health behavior you're trying to achieve? And the other thing I say is always go back to being a human, because when you think about health-seeking behavior in general, communication works different ways for different people. And every year what you're trying to do is continue to try and communicate that same message to get people to take action in a different way, because what resonates with one person won't resonate with another. Then the same thing about how they access it. So it's not that you put in a mental health app, you can take away the face-to-face visits, because everybody likes to seek their healthcare in different ways. So it's about continuing to diversify the opportunity to engage in that health behavior that you're trying to achieve, so how they access it. And then there's the motivation aspect of it, because I always say we all know what to do, we know what's good for us, what's bad for us, but we don't do it. So what motivates us, which is about, 40% of behavior change can be your environment, 20% is skills and tools, 25% is motivation, and education and awareness is the last 5%. So what motivates people? Again, for some people it might be something as challenge as social recognition. In healthcare, storytelling is the best tool that you can use, someone who has gone through it and it's worked. So it's not about that you put in an app, it's not about what you put in, it's how you put it in, and continuing to diversify and evaluating what's been working, what's been not working, and you continue to grow the program that way.
So I want to come across to Jake just to pick up on that point, because I know you have, I don't know how much you can say publicly because you're still working on it, but I know you've been looking a lot at data and building on what Dana's just said.
First, the bit I love about what Dana just said, it's about the experience for people, and it's about not having singular points of contact or singular things that people go engage with, because we know that different people want different things. And if we try and implement, especially on a global level, if you say everyone must use a singular tool, I'd like to see somebody that has made that work. But I can share what I'm trying to do, which is, and we're now from our people analytics are looking at how we can do this to actually report the impact side of things. And it's that bit of taking a well-being index, and there are so many questions you can ask people. I think it's always good to start with what you can, and probably the best top level that we have is the Oxford Institute 4 questions, so around purpose, happiness, stress, and I always forget the last one. But it's a good place to start, and then can you map that to then what are the outcomes that people are having? So are people off sick more? Are people leaving more on a voluntary basis? And are people taking holiday? Because I think it's such an overlooked measure. But if people are taking holiday, and I've seen this in 3 organizations that I've done this study, is that people that don't take as much holiday as they are allowed often are the ones that report higher levels of burnout or lower employee engagement. Now, it's not saying that it means that you need to have everyone take loads of holiday. It just means that it's a good thing to look at to start to see where the behavior is. And if you do those 2 things, and then the third thing is then looking at how do we look at best practice on a local level, and how do people provide that best practice? And we're looking at, I did a project last year with Deloitte looking at the World Business Council for Sustainable Development maturity matrix and how you can utilize some of the tools out of that. I think those 3 things give you some insight into how do people feel, what are people doing, and what are you doing as an organization? And then you can start to tailor what you're doing at a local level based on those 3 things.
I've got 5 minutes left. I know you're desperate to say something, but so I'm going to throw this question to you, then we can wrap it into one, because I don't want to miss the opportunity to also ask a question that's coming up quite a lot. And this is around what you've just talked about, tailoring your offerings to everybody, and it just feels like it's more and more and more, and we've got to offer more benefits for more diversities in the workplace, and it's just how on earth do you manage cost? Use a question here about how do I have equitable propositions for small locations, but even big organizations say this all the time. So that's what I want to just tap into that. How do we manage this ever expanding gamut of different well-being products that we've got out there and keep control of costs?
Well, I mean, this is when I look at it from a medical benefit perspective, and we've talked a lot about this a little bit earlier, I see that trend especially happening for the captives, because they use the captive as a tool to ensure normally not insured benefits. So what we've seen over the last few years is that especially under the captives, the medical benefit has been expanding and add-on services have been put in. And that does have an impact on the costs. And as Dana said earlier, you can cost that in, but the money has to come from somewhere, or you have to somehow put kind of levers in to manage those costs. So we do see that a lot of companies are doing that also because of talent acquisition and retention reasons, right? And I think that's something that we haven't really talked about yet, that employees are getting more demanding and are expecting more from their benefits when they join a company, right? And the younger generation does have certain expectations to come in. And now I've lost my track, but great.
It's about the demand for more and more and offering more and more, and the pressure.
So
how do we manage that?
I think you mentioned that earlier. It's always the balance between the fit for purpose benefit and having the best in class benefit. I think that is what you as an employer have to decide on which side you want to be, and then managing the cost is definitely something that you have to work with your insurer on to kind of find the right level of benefit that allows you to control costs while providing more possibilities for using the benefit.
And I would just say that because across DHL Group in some countries, I mean, we have a lot of different locations and they're smaller, it doesn't take a lot to have a big impact. So again, at a location where, and this is where we actually work very closely with our occupational health team, if you have a nurse on site who can help support and deliver some things that they have that access to, number one, that feeling of being cared for is there, but number two, it has a greater impact. You don't have to go out and buy the greatest, newest app when you're just trying, again, to achieve that health behavior. And if you start with that, then you can think simple and think low cost.
Yes.
I think the point that I wanted to add to the conversation earlier was really around the storytelling, right? We're talking about all the add-on services, but I want to pick up on I don't know who was in the keynote speech earlier, where you asked the question around, at the beginning, around who knows about the benefits, and so many people answered, nobody knows about their benefits. So how do you communicate about the benefits, whether that is the app or well-being service that you provide, or your medical service, or your dental plan? How do you communicate about them, make it interesting? I mean, medical and dental insurance is really not the most exciting thing to talk about, but what is exciting is to hear people who've actually had their life changed because the company provided the benefit. So how do you communicate about the benefits is, I think, a really important point.
That's a really important point, and I'm going to come back to each of you in a moment for your one key takeaway from today that you're going to share. But I'm going to jump in first on that one, because what our research is showing, and what speaking to some employers, they're becoming a lot tighter on, is this a health issue linked to work? And is it about bringing people back to work and making them productive? We'll support that, but if it's a broader thing, and knowing where your line is at your organisation, some people can't do everything for everybody all the time, and there is individual responsibility, which comes through very strongly in the new wellbeing research that we've put out today. There is a shift onto individual responsibility. So just a different way of thinking about it. So quickly, starting with Dana and going down the line, one key takeaway from discussion today.
I would say to really focus on, again, think about health outcomes and think about what you're trying to do and how you can do it, and always remember that people are human, because I think if you look that way, there's never going to be a quick fix, but you can see that growing year over year and the actual health behavior change.
Brilliant, thank you. Danny?
Cross-department approach to health and well-being. So that is my so whether that is employee benefits, captive management, pooling management, HR, work health and safety, finance, you have to work together otherwise, and find at least one goal that you're all working towards together, which should be something around, we're working with people here.
Fantastic. And Jake?
I can't add anything that's better than what's already been said, but I'd say that exactly what everyone said around storytelling is that if you can create a meaningful story and a meaningful experience around how people engage with health and well-being within your organization, it will then amplify everything that we've already talked about.
Brilliant, thank you very much. If we just bring up the rating for the session, let us know what you thought about it. I can't see the slides, so you can say what you like. Just be honest, it's really helpful. And a huge thank you to our three panelists.